Hello everyone. Today we have very interesting case to discuss. So here this was the young male patient who was having severe right-sided leg pain. He was walking with the forward stoop and list on the one side. So he was very unresponsive to the all modalities of conservative management. I tried to conserve him for a month, but gradually his pain was increasing. The thing is that his pain was out of proportion to the MRI findings. So let's just discuss the MRI first. Here you can see the X-ray. There is no instability in this X-ray. So we'll discuss about the MRI. So here in sagittal image you can see there are two levels. One is the L4 L5 level and the other is L5-S1 level. So this patient was classically having the S1 pain, so I simply ignored the L4 L5 level here, and at L5-S1 level you can see there is a central annular tear, and in paracentral image the annular tear is opening on the opening towards the superior upper end plate. So in the axial MRI you can see here there is a central annular tear, not too much of the compression here, but if you give proper attention to the right sided facet here, you can see the right sided facet is showing some hyper intensity compared to the left side facet. So you may feel this might be a facet effusion, but this signal was white or hyper intense on T1 image as well. So I don't know why that facet was showing hyper intensity in both T1 and T2. So again on the right side you can see the root is getting compressed between the disc and the superior articular process on the right side. So after studying this MRI and X-ray carefully, I am still not convinced about the severity of the pain patient is having. So finally I decided to decompress the right sided lateral braces, and during surgery I find some interesting things. So that is the reason I want to share this case with you all. So let's move to the endoscopic picture. During this surgery, I observed four important and somewhat unusual findings. I don't know whether these findings are attributed to the pathology or the severity of the pain, but let's discuss these findings one by one. So this is the finding number 1. This is not an unusual finding. This is one of the commonest finding when you are dealing with the annular tears, where you can see the right-sided traversing nerve root is congested, swollen and hyperemic. You can also see the size of root is increased because of the congestion only. So this is the one finding which I observed in this patient. Here you can see that there is an epidural vessel running from the lateral border of the traversing root into the lateral recess. So this particular vessel is not allowing the traversing nerve root to move, so thereby reducing the mobility of the root. That means the same vessel which is responsible for the congestion of the traversing root is also causing root to become fixed. I freed the traversing nerve root by cutting the adherent epidural vessel, but the question is, can it be the cause of disproportionate pain in this particular patient? So one more unusual thing in this patient is, you can see here there is a big epidural vessel just lateral to the traversing nerve root. Actually it was underneath the traversing nerve root. Once I decompress that area, the root has shifted medially. So you can see here there is a big vessel which is lying just lateral to the traversing nerve root. So retrospectively speaking, is there anything abnormal on the right lateral recess? So if you look at the axial MRI again, on the right side, this particular anterior epidural vessel is deforming the traversing nerve root. I don't know whether this is contributing to the symptoms or not. There is one more finding here. If you look at the 3 o'clock position, there is a inflamed synovium which is herniating from the joint, the right sided facet joint. So this inflamed synovium can cause the irritation of the traversing nerve root, which may be the cause of disproportionate pain in this patient. The last and I think the most important finding in this patient, so the moment I cut the outer annular layer, you can see here there is a vascular granular tissue which is filling the annular defect. So these are the inflamed tissue which keeps on leaking the inflammatory mediators, which irritates the traversing nerve root, and that again explains the chronicity and the severity of the symptom in this patient. So here I expose the entire length of the annular defect and ablated all the inflammatory tissues which are lying into the defect. So this is the video of final decompression. So these were some interesting and unusual findings which I encountered during this surgery, and I wanted to share with you all. Thank you very much.